Next. Let me start by introducing the subject that Beppy and I and many of the others who are speaking to you today have been passionate about, and frame this very much in the notion of not just improving mental health for all people, but especially achieving equity in mental health. And that simply means justice in the way that mental health is experienced around the community, in between different groups in the population, as well as justice in the way that mental health care interventions, including prevention, are accessed by all people. And I also wanted to emphasize the word worldwide. Historically, we've often thought of global health simply as needs of people in countries like Peru, India, and other developing countries. But as we will see, in fact, there are enormous unmet needs even in the wealthiest countries of the world, and the issues of justice and equity are just as relevant in the US, for example, as in Peru. Next. Let me start very briefly by telling you about the challenge. I want to spend more time with the opportunity. So I'm going to go a little quickly on the next few slides, because most of these will be familiar to you all. Next. This slide simply tells you two important things. First, that no matter what kind of country you live in, what you see here is countries of the world organized according to how developed they are economically and socially. The blue line at the bottom are the least developed countries, and the red line at the top is the most developed countries, and then you have the other countries organized in lines in the middle. What you can see across all of these lines is two things. Firstly, the more developed a country, the greater the share of the burden of health problems that are due to mental and substance use conditions. The reason for this is not because these conditions are more common in rich countries, but because rich countries have fewer other health conditions to deal with. For example, much less TB, much less malaria, much less undernutrition. The second thing you can see from this slide, next, is that no matter which country you live in, whether it's Peru, whether it's Burundi, or whether it's in the US, the burden has increased by 50% in the last 25 years. And this is also for two reasons. First, because countries have been much more successful in controlling these other medical conditions like heart disease and cancer and infectious diseases, and done very badly with mental health. And the second reason is visible on the next slide. Next. And on this slide, you can see the burden of disease for men and for women arranged across the life course. And what's very clear from this slide is that most of that burden falls in young adulthood between the ages of 15 and 45. We all know that this is perhaps the most important group in our population. This is not only the economic engine of every country, but it is also the social engine of every country. The group that will fight for rights and for social justice. But it is also the group that is most vulnerable to develop mental health problems. And one of the reasons for the increase in the burden over the last 25 years has been the increase in the number of young people across the world, but especially so in developing countries. Next. This slide shows you the numbers of deaths that occur each year due to mental health problems. And what you can see is that if you had to look at deaths that were specifically due to mental health problems, the numbers are quite small. And it's important to remember that mortality is a very important driver of policies and priority setting. And so if one looked at this slide, we would assume that mental health problems were not a very high priority, at least in terms of mortality. But if you look at the bar, which is longer, the blue bar, you will see that we were able to calculate the excess number of deaths that occur in people who have a mental health problem that would not have occurred if they didn't have that problem. Let me give you a good example to make this point clear. Alcohol use conditions do not directly cause any death. However, they do cause death due to accidents and injuries and due to liver disease. So if you add those two causes of death, then you get a much bigger contribution of alcohol to mortality. Similarly, suicide is largely due to mental health problems, but it is not a direct result of the mental health problem. And again, most suicide deaths would be counted as excess deaths. So mental health problems are associated with huge mortality, as well as, especially I should point out, that mortality is greatest in some countries in younger people. For example, in India, suicide is the leading cause of death in young Indians. In the US, suicide is the second leading cause of death in young people. And in the US, incredibly, in the last 10 years, suicide rates in young Americans aged between 15 and 24 has gone up by nearly 50%. That is an astonishing fact. The suicide mortality in the US, but also in England and in Australia in young people, these are good countries that I use because they have the best, most reliable suicide data, has gone up by nearly 50% in the last 10 years. It's astonishing and deeply worrying. Next. This is a slide simply making the point that people who live in conditions of poverty are much more likely to develop mental health problems. And I think it's an important point to make, because oftentimes in countries like Peru and other developing countries, the diseases that are associated with poverty are the ones that get prioritized. And therefore, by demonstrating that people are at greater risk, we're able to also say that these are diseases of the poor. But importantly, also, we are able to demonstrate through this slide that if you have a mental health problem, you are more likely to slide into poverty, which means that in order to actually break this vicious cycle, not only do we have to reduce poverty, which of course is important in and of itself, even if it had no relationship with mental health, but also by preventing and reducing mental health problems, we can reduce poverty. And therefore, this is a slide that calls to attention the need for investment in mental health. Next. Now, with all the evidence on burden, what do we know about the important question of what proportion of people in the population are able to access care for their mental health problems? And on this slide, I'm going to show you the summary of coverage for depression, anxiety, and substance use conditions in countries that are high income or wealthy, or low and middle income or developing. Next. And here you can see the coverage rates in low and middle income countries, and astonishing figure again, more than 95% of people with anxiety, depression, or substance use condition did not receive minimally effective care in the previous 12 months. Next. Now, you'd expect the figures for high-income countries to be a lot better. They're certainly better, but I don't think they're a lot better, especially if you consider that a country like the US spends 1,000 times more in mental health care and has 1,000 times more resources for mental health care than most of Africa or Asia. It is not at all impressive that their rates of coverage are not 1,000 times more in many ways, right? And I think the point I think we should take away from this, and I'll come back to this, is that simply spending more money is not the solution to reducing the very large gaps in access to good quality care that you see globally. Next. And another huge problem, and I hope you don't see this in Peru, these images are from mental hospitals that come from Serbia, from India, from Indonesia, and from Chad. So even for the few people for serious mental illness who receive some care, this is often what care looks like. These are, of course, horrific images of places that are called hospitals, but I don't think these are hospitals. They look like torture chambers that were built often by the colonizers who colonized some of these countries 50, 70, 100 years ago, but remain the major providers of mental health care in developing countries. I hope that this is not something you see, as I said, in Peru, and maybe in question and answer, we can return to this question of human rights. People often worry about stigma and discrimination about mental health problems, and I think much of that stigma is produced in psychiatric hospitals because people are fearful of being admitted and often disappearing forever into these sorts of terrible places. This is why, next, my mentor, Arthur Kleinman, and Beppy's mentor too, has described the situation of global mental health as a fundamental failure of humanity. Now, these are not images we will see in rich countries anymore, next, but what we've done in rich countries like the US is simply replace the bars of the mental hospital with the bars of a prison. So that you have this incredible figure that in most of the states of the US, there are more people with serious mental illness in a prison than in a psychiatric hospital. And even last year, several individuals with a serious mental illness or an intellectual disability were actually executed in the US for some criminal offense, completely against their fundamental human rights to life, and indeed even more so, the fact that they had a significant mental health problem. Next. Friends, we all know we're going through very difficult times. The COVID-19 pandemic has both been an opportunity and a threat for mental health. It is an opportunity because it allows us to re-examine the world that we live in and hopefully make significant permanent changes to create more justice, more fairness, more equity. But it is also a huge threat. There is a dramatic increase in poverty around the world. There's a dramatic increase in inequality around the world. And we know that the combination of poverty and increased inequality is a poison for mental health. The 2008 financial recession, which was a relatively limited one, it only affected the US mostly, was associated with a reduction in life expectancy in working age Americans, something that the Nobel Prize winning economist Angus Deaton described as the deaths of despair in a book that was published in April this year. I fear that unless we not only reinvest in mental health care, but also reimagine mental health care, we will face a similar wave of deaths of despair, not just in the US, but in fact, around the world. Next. In 2011, we published the Grand Challenges in Global Mental Health, because of course there were huge challenges in global mental health even before the pandemic. This was a work led by the National Institute for Mental Health of the US, which I co-led with Pamela Collins. We identified a series of research priorities that, if they were addressed, would contribute to the reduction of the global burden of mental health problems. These priorities were by and large implementation science priorities, which means research to do better with the knowledge we already have. For example, the knowledge of effective interventions for prevention and care, to be able to deliver them to wider sections of the community so that the care gap that I showed you earlier can be dramatically reduced. Over the last 10 years, more than $500 million of research funding has gone in to fund these challenges. And today, next, I can confidently tell you something that I couldn't have said 10 years ago. We know how to deliver clinical and preventive interventions in every setting of the world, in any setting of the world, using resources that every community has. And I think it's a really important point for me to stress that for so long, we have often felt defeated by the idea that we do not have enough resources. For example, we don't have enough mental health specialists. Today, the question is quite different. It is, how do we use the resources that every community has? And in my experience, every community is rich with the most important resource of all, people who care for each other. How do we leverage this tremendous resource in the service of mental health? Next. This large body of evidence has completely redefined mental health care in 4 important ways. First, how, or rather, what is mental health care look like? Mental health care in all of these programs involves a simplified version of the very complex psychosocial interventions that mental health professionals typically deliver. The good news is that even these simplified treatments or interventions for prevention are hugely effective. Another very good example of the what is to combine clinical interventions with interventions to help the person deal with their social problems. Because you and I know that mental health problems and social problems almost always exist together. To separate them out is completely artificial, not least in the mind of the person with a mental health problem who sees their problem as being just a continuation of their social suffering. Second, mental health care can be delivered anywhere where the person is in need, rather than only in a hospital or a clinic where there is a mental health professional. Nowadays, you can even deliver some kinds of mental health care through smartphones on the internet. Third, anyone in the community with a calling, with a desire to learn and to be involved in mental health care can deliver mental health care. This is, of course, one of the most exciting revolutions in mental health, in global mental health. And finally, how? Of course, we must remember the need for carefully designed training, supervision to assure quality, but also to support frontline workers. And also, we must recognize that one size does not fit all. Some individuals will need more than just the frontline worker mental health care, and therefore we must ensure that frontline workers are working in an organized mental health care system in which they can refer people who have more significant needs to a mental health specialist. Next. This evidence is transforming global policy. Here I've just shown you some examples of various policies and programs at the United Nations level, the World Bank, the World Health Organization, which now speak to the scaling up of this kind of mental health care. You know, it's amazing. 10 or 15 years ago, if I had said what I've just said to you a moment ago, people would have attacked me and said there is no evidence that what you're saying is safe and it is effective. Today, not only is that evidence strong, but it has also now been accepted by the world's leading agencies that are involved with guiding countries on what to scale up. Next. I want to close by looking ahead. This evidence is extremely exciting also to global mental health scientists. And a few years ago, the Lancet Medical Journal, which is published in Britain and is the world's leading global health journal, invited me to assemble a group of 28 global mental health practitioners. I was joined by my colleague Shekhar Saxena, who then was at WHO and now works with Bepi and me at Harvard University. We put together the Lancet Commission on Global Mental Health and Sustainable Development and spent a number of years thinking about how is this transformative evidence on how one can deliver mental health care in any context. How do we actually translate that into a meaningful impact on reducing the burden of suffering for people with mental health problems? Time doesn't permit me to go through every single piece of this commission, but I want to just leave you with certain high-level recommendations that arose. Next. Next. First, we must look beyond narrowly defined and diagnosed mental illness. This is a very important point I want to stress. For far too long, we have dealt with mental health problems as if it is a diagnosis exactly the same as a physical medical diagnosis like TB. We know this is not true. This is neither true in the sense that neuroscience does not clearly distinguish people with and without a mental illness, but it is also not acceptable for many of the people that we deliver care to. People don't like labels. They don't necessarily need diagnoses, and there is no neat way to divide up the world into a binary of with and without a disorder. Second, we must look beyond treatment and clinical interventions and focus attention on prevention. And to do this, we must target the structural and social determinants such as domestic violence, such as deprivation in early childhood, such as the lack of good quality education that we know profoundly affect mental health across the life course. Third, when we talk on mental health care, we must give equal importance to psychosocial interventions. I always say we need to look beyond the 3 Ds that have dominated mental health care: doctors, diagnoses, and drugs. We must recognize the important role of psychosocial interventions delivered by frontline workers and emphasize the quality of the care that they receive. And finally, and I am very strongly passionate about this idea, that we must all work towards the aspirations of the CRPD, the Convention of Rights of Persons with Disability, so that one day, and one day very soon, we realize a world in which mental health care is given in a rights and disability rights focused way, so that all forms of coercion in mental health care and all forms of long-term institutionalization in mental health care are completely eliminated. To me, the presence of coercion in mental health care is one of the greatest challenges when it comes to stigma and discrimination. And I believe that we now have a real task ahead, and we have some ideas, particularly through empowerment of people with a lived experience on how we can actually address and ultimately eliminate coercion. Next. I want to end by telling you that we have an initiative in Harvard that was launched a few years ago, and Bepi has been a great partner and a colleague and a member of the steering committee. And our goal in this initiative in Harvard is to work with our partners around the world, including, of course, PIH, in ways to actually implement some of these recommendations. Next. And one of the things I want to just leave you with is an initiative that I'm very excited about, which is a digital platform, not to deliver mental health care directly to people so they sit with their phones and try to figure out how to address their depression, but instead to help the frontline worker learn, master, and deliver quality assured psychological treatments. Next. And so what we're really doing here, and this is work that has just begun about 6 to 8 months ago. I'm extremely excited about this because this is about genuinely scaling up the quality of care through psychosocial interventions delivered by frontline workers. We're building digital components to enable frontline workers to learn psychological treatments that are evidence-based, to then undergo case-based learning so that they can master the treatment and then have lifelong support and supervision for quality assurance, and ultimately to use these digital tools to actually inform mental health care systems of the impact of this kind of scaling up on population mental health. Next. We've already started work, first in India, with a brief 6-session treatment for depression, which is based on behavioral activation. Next. This is a picture of the app that my Sangat is like a PIH in India. And this is a picture of the app that's been developed for frontline workers to learn this brief behavioral activation treatment for depression. It's available on an app. Next. And now what we're doing, next. And this is really exciting. We're taking a treatment that was designed and trialed in India, and we're delivering it in the US. Indeed, in fact, it's already been adapted for delivery in the US and in Canada by frontline nurses for maternal depression. But we are now working with partners in Texas, where the Empower platform will be used to train community health workers to deliver a brief psychological treatment. And what's really exciting is that the American Psychological Association, which is the world's biggest professional association for psychologists, has become a partner to Empower. And I say it's exciting because you can imagine that specialist professionals would feel uncomfortable about us using brief versions of treatments that psychology has developed and really created amazing science out of, and that they would be very concerned about this. But I think the present leadership of the American Psychological Association recognizes the importance and urgency of task sharing to come to the US. So this is something we're doing simultaneously in India and the US. Next. We're also working towards similarly developing the curricula for maternal depression. This is a program for mothers with depression called the Thinking Healthy program. And next. And in the light of COVID-19, we're now working with WHO to develop the online curricula. And this is not just for community health workers, this is for anyone in the community, because these are not clinical interventions, but these are actually preventative and promotive interventions, such as psychological first aid and self-help. Next. Ultimately, what Empower is going to seek to do is that you can imagine at the left-hand side, you see a community health worker who has no previous experience in mental health. She completes her online course and becomes a competent learner, but is still only a learner. Then, through case-based learning, becomes a competent provider. And then over time, as she delivers more and more care to more and more people, she becomes an expert. And then as an expert, she can go back into training and supporting the new generation of learners. So you can see there is a self-sustaining cycle, and it's important for me to stress that this means that there is no need in the long term of experts at all, because your experts are actually coming from your own community. Next. And so what we have is, as COVID-19 creates a rising demand, the current system, which is very, very top-down, is unable to actually supply enough care to people in need of demand, or in demand of mental health care. And instead, at the bottom, you see how Empower seeks to work by actually tremendously increasing the base of the pyramid. I think Betty spoke about the pyramid. This is the base of the same pyramid, where you empower community-based providers to actually deliver mental health care, and therefore the numbers of people who get helped is much greater. Next. So I think I'll go through this quickly because Beppy's already gone through this, and I'd like to take some questions. If you can just rapidly scroll through this slide. Beppy already spoke about all of this, about things that each of us can do in mental health. Just leave it for now, and you can just look at this list. I'm not going to speak about these because he did a really great job in speaking about them, but I'm very, very happy to actually also talk about any of these self-help points that if anybody has any interest. All right, and go to next. In closing then, I believe that this pandemic presents a really historic opportunity for us to invest in and transform the mental health care systems of our countries, of our communities. And there's no question, this year's World Mental Health Day is about let's invest. And yes, of course, we need more money. But I want to be very clear that we need to spend it wisely. And to spend it wisely, we have to be guided by the best science. And for us to understand that science, we must embrace the diversity. The diversity is immense of experiences. It's not just about disorders and diagnoses. It's much more complex and diverse than that. And equally, we must embrace the diversities which work beyond the narrow emphasis of doctors, diagnoses, and drugs. Thank you very much. Muchas gracias. Yeah, I think that's my last slide.
Thank you so much, Dr. Patel, for your presentation. We have some questions from the audience, and we have about 13 minutes to take a couple of questions. Our first question from Rolly Madden is, what is the difference between normality and anormality?
There is no fine line between these two, and I think this has been the problem in the mental health field. We have tried to pretend that we know that fine line, like in the way in infectious diseases, we can draw the line between those who have TB and those who don't with a blood test. And we have assumed that we can also draw that line, and we have hoped that we might come along after 40 years of research to discover that kind of line, but there is no line. And now we know there never will be a line as precise as we have for infectious diseases because of the very nature of mental health problems. So instead, I find it more useful to ask the question, when do we know that a person might be suffering from a mental health problem that could benefit from a clinical intervention? And I use three different parameters to guide my thinking. First, how long have your distress been present? Usually I'd say at least 2 weeks for most of the day. Second, how many different experiences are you having that are causing you distress? If it's just worrying about one thing, there's much less significance than if you're worrying about many things, you can't sleep and you're losing hope in the future. So mixture of different kinds of features that affect your thinking, your feelings, and your behavior. And third, if it is interfering with your daily life, whatever that daily life might be, if you're a student in your studies, or if you're at home losing your temper with your partner, etc. If these three occur together, in my mind, that is perhaps the best indicator that the person could benefit from a psychosocial intervention or a drug intervention if the need is such.
Thank you so much. Our next question is from Luis Vilches. He says, not long ago in Peru, we also had unfortunate images such as those that you have shown in relation to asylums. What should be the transition process from shelters to the community? The immediate destruction of the culture of asylums is unfeasible. So what would be the best strategies based on your experience?
I completely agree with that question, with that recommendation. I would never suggest the complete closure of asylums unless there was something alternative in place. I think I was a psychiatrist in London in the 1980s, London, England, when exactly that is what happened. And I have a visual memory of seeing hundreds of people living in cardboard boxes and shelters under the bridges that cross the River Thames in London. It was a harrowing sight. And it was because of this idea we needed to close the institutions, which of course the right-wing government at the time was very happy to do because it meant less expenditure, but without any effort to actually build the alternative service in time. So I would first invest in the alternative service. And what does that comprise? Three things. Firstly, reforming the hospital. I don't think you need to shut the hospital down necessarily. I think these hospitals can play very important roles in our countries. They can be places of training. They can be places to actually have a destigmatization of mental illness. They can be, but especially they require to be reformed for that. The opening of all the doors, the unlocking of all the walls, the removal of all seclusion, the removal of any form of chaining in hospitals, and so on and so forth. And I'm sure you know what I mean. They're literally the opening up of the hospital like you have for any other hospital. The second thing is to build community-based workforce so that when people are discharged, they are supported in their homes, in their communities, for all the essential needs that they have. And for people with serious mental illness, oftentimes those are to do with their social needs. For example, finding work, having friends, having a social life, being able to look after their physical health, and so on. And so these are the two key strategies. The third, and I think this is a little bit more controversial, but I think it's much clearer in my mind, is we do recognize that some people will need long-term residential care. And I think, therefore, the development of community-based small residential facilities with support in them would, I think, be the third piece of the entire, the entire solution. I want to alert you to a very interesting initiative called Clubhouse International, which I discovered some years ago, which you might want to look up on their website. It's an incredibly good example of how people with serious mental illness can create their own spaces in the community, literally as a club, which is non-clinical, to provide essential interventions to do with social support, befriending, giving a structure in the day, and helping people learn skills to go back into the workforce. There are more than 300 clubhouses now around the world, and I believe there are also now some clubhouses opening in South America, but I'm not sure if there's one in Peru. But I would urge you to look at the clubhouse model, because I think it's a wonderful example of empowerment and community support for people with serious mental illness, and a very evidence-based one as well.
Thank you so much. Our next question is from Maria Rodriguez. She asks, in what way could one help or intervene with psychiatric patients who are abandoned by their families in a mental health center?
Yeah, this is a huge challenge. I mean, I see this in India as well, not just mental health patients, but also, for example, older people with dementia. It's one of the most tragic sites of all, where people with dementia are just dumped outside an old age home, and then the old age home will not take them because they don't take people with dementia. And it's heartbreaking. And oftentimes, ultimately, these individuals will die prematurely because of poor medical condition. So I think the only solution in the long term is supported residential care. We do need to have shelters, but they have to be humane shelters. They have to be small. They have to have a semblance of everyday life being there, rather than holding cells like prisons where we keep people. Let's not forget for a moment the tragedy of COVID-19. The biggest tragedy of COVID-19 has been the way older people in the US and Europe were housed in old age homes with no transparency, no accountability, no oversight. It may shock some of you to learn that more than 50% of people who have died in many of these countries were in old age homes. And I think it tells you something not only about the vulnerability of older people, but the fact that they were living in these crowded homes with very little public oversight. So I think we have to be mindful that these sorts of shelters can become dumping grounds. And we have to be very, very clear that these are not dumping grounds, but these are places of housing in which the goal is to maximize inclusion of people with mental health problems but also reducing their vulnerability so that they don't become homeless.
Thank you, Dr. Patel. Our next question is from Carlos Bromley. He asks, how can we incorporate the spiritual component into mental health care?
Yeah, I have very much less experience on the spiritual side, but I do know that in many cultures and contexts, the spirit world is inseparable from mental health and indeed from physical health. And so acknowledging the spirit world is extremely important. I don't believe that those of us who are more biomedically trained have to therefore become spiritists, but I think that at the very least, we should accept and acknowledge that our patients or the people we're working with do have a very strong spiritual connection, to be able to respect the fact that they are likely to be seeking help from priests or traditional healers who give attention to their spirit world. And I was just reminded, as the question was being asked, of this tremendous piece of work from Nigeria that was published only last month that showed that biomedical services can collaborate with traditional healers in the long-term care of people with psychosis. And in doing so, they can actually improve the overall outcome of people with serious mental illness, demonstrating how you don't have to necessarily be all in one, but you can collaborate across these different sectors. And in doing so, you can actually improve the overall impact of your care on the person who you are concerned about.
Thank you. Our next question is from, anonymous. Someone asks, would you share some resources to talk about mental health, specifically prevention within youth and adolescents?
Yeah, absolutely. The most important prevention for youth and adolescents is school-based. For those who are in educational institutions, are interventions that target the social environment of schools. We know that this is the most cost-effective intervention. It's also the same program that is used to promote physical health. And essentially what you're doing is targeting the same determinants of poor mental and physical health, things like bullying, things like being excluded, things like not having their concerns and priorities met, and so on. The second is life skills training, which is, again, done in a very boring way, in a classroom curricular way. But the idea is very good, which is building the social and emotional competencies, for example, for emotional regulation. And so if it is done in a much more youth-friendly way, it is also extremely impactful. I think there is some evidence also of providing low-intensity interventions like problem solving in school settings. The main point here is that it's all done in the educational institution. For those who are outside the educational institution, obviously it's a lot harder because many of them are already in the workforce, and some of them, especially women, will be married and be parents. So I think for that community, you would have to really deal with them in very much the same way as you deal with adults with mental health problems.
Thank you so much. I think we have time for just one more question. This last question is from Vanessa Herrera. She asks, what recommendations would you give to approaching mental health care in women affected by violence within the model of community-based care and mental health reform?
Well, I think the one thing we know for sure is that women who have been affected by violence, first and foremost, need their violence addressed. There's no question that's a priority. And I'm not going to go down that, what all the things there, because that's something which I'm sure many of you already know or have other access to resources to, but, safety, shelter, etc. The second thing is, I think we must address their mental health needs. Many women who have been experienced violence will also be experiencing depression, suicidal ideas, substance use, etc. So providing evidence-based interventions. And we know that actually in doing so, you actually help the woman also be much more effective in dealing with her perpetrator and the violence. The third, and this is something we don't do enough of, is engaging men. And I would really hope to see that we see a world in the future where men and women are both equally involved in addressing gender-based violence. I think we need to recognize that men are also oftentimes affected by gender disadvantage in different kinds of ways. Many of the men who are perpetrators have themselves grown up in families where they themselves were victims of abuse, or they saw their fathers beat their mothers. They've been traumatized themselves. They often have substance use problems. And ultimately, often I see the issue of violence as a relationship problem. So where a woman and a man are happy to seek help, providing couples interventions and helping the man with his own anger management, his substance use and trauma history would also be very important. But I want to just stress, I'm not suggesting that I'm absolving the person of any kind of responsibility for their behavior, but I'm just trying to explain that in the longer term, we must engage men as equal partners in addressing violence against women. Well, thank you very much to all of you for this wonderful round of questions. It's been a real wonderful occasion. I'm so sorry I couldn't speak in Spanish. I know I would have reached many more people, but thank you for your patience, and thank you to the interpreters for being patient with me.